Hello everybody. Welcome to No1doctor channel. Today we will discuss one of the common surgical problems. Welcome doctor.
Welcome doctor for you and for your channel subscribers.
Doctor. A 30-year female patient has come to emergency with acute pain in right upper quadrant of abdomen. How will you proceed to manage?
The important causes of acute pain in right upper quadrant of abdomen includes acute cholecystitis, acute cholangitis, acute pancreatitis, acute peptic ulcer, peptic ulcer perforation, liver abscess, acute retrocecal appendicitis, acute intestinal obstruction, right-sided renal colic, acute right-sided pyelonephritis, acute myocardial infarction, basal pneumonia, Mrcs.
Doctor. What are the non-surgical causes of acute pain in the abdomen?
Important causes of non-surgical acute pain in the abdomen includes acute myocardial infarction, basal pneumonia, acute intermittent porphyria, sickle cell disease, diabetes mellitus, acute epilepsy. For rational management, a detailed history, physical examination, and some relevant investigations are required. Treatment will depend on the underlying cause. History will include detailed history of pain, onset, cited onset, duration, progress, radiation of pain, character of pain, relation with food, aggravating and relieving factors, similar episodes of pain earlier, associated symptoms like nausea and vomiting. If vomiting is present, inquire about duration, frequency, times per day, relation with pain and food intake, character of vomits, amount, sour or bitter, bile is bitter, contents color, yellow, green, coffee ground, frank red, history of jaundice, fever, loss of appetite and loss of weight, history of sensation of fullness of abdomen after meals, heartburn, belching, bowel habit and any alteration of bowel habits, urinary habits like frequency, burning sensation, history of hematuria, other symptoms like chest pain, cough, hemoptysis, breathlessness, diethyls menstrual history, history of past illness, about similar attacks of pain in the past, history of peptic ulcer disease, white discharge per vagina, any mass in the abdomen, physical examination, general survey, look for features of shock, pulse, tachycardia, feeble pulse, blood pressure, hypotension, cold and clammy extremities, dry tongue and collapsed veins. Look for nutrition, jaundice, pallor and temperature. Local examination of abdomen. Inspection. Look for any fullness or distension. Any restriction of movement of right upper quadrant of abdomen or whole of abdomen. Any visible peristalsis. Any ecchymosis around the umbilicus, Cullen's sign, or in the loin, Gray-Turner's sign. Look at the hernial sites to rule out any hernia. Presence of any lump and detail examination of the lump. Palpation. Look for tenderness, rear-bound tenderness, muscle guard and rigidity. Look for Murphy's sign, elicited in acute cholecystitis. Rothsing's sign, So's sign, obturator sign, elicited in acute appendicitis. Any palpable mass gallbladder may be palpable in acute cholecystitis or empyema gallbladder. If a lump is palpable, details examination of the lump. Whether parietal, intra-abdominal or retroperitoneal, position and extent of the lump in different regions of the abdomen, size, shape, surface, margin, consistency, mobility, whether bimanually palpable and palatable. Palpation of liver, spleen and kidneys. Percussion. Look for general notes of the abdomen and evidence of free fluid in abdomen by eliciting fluid thrill or shifting dullness, suggests perforative peritonitis. Obliteration of liver dullness found in perforative peritonitis. Delineate the upper border of liver and spleen by percussion. Intercostal tenderness during percussion may be found in liver abscess.
Doctor, what about auscultation?
Peristaltic sounds. Present or absent. Any audible bruit or venous hum. Perrectal and pervaginal examination. To exclude any pelvic mass, pelvic collection or tenderness. Systemic examination. Examination of respiratory system to exclude basal pneumonia or epimethoraces. Examination of cardiovascular system to exclude acute myocardial infarction.
Doctor, what about the investigations?
Complete hemogram. Leukocytosis and acute inflammatory conditions. Urine analysis. WBC with or without RBC in urine suggests acute UTI. Retrocecal appendicitis lying in contact with ureter may cause minor pyuria. Serum amylase and lipase. Elevated level suggests acute pancreatitis. Liver function test. In patients with suspected hepatic and biliary tract disease. Chest X-ray PA-view. To rule out basal pneumonia and to look for free gas under the domes of diaphragm found in hollow viscous perforation containing gas, like peptic ulcer or gut perforation. Steroid X-ray abdomen. To look for dilated loops of bowel, air fluid levels. Ultrasonography of abdomen. Helpful in hepatobiliary diseases, pancreatitis, appendicitis and renal diseases. CT scan of abdomen in selected cases. MRCP in selected case for diagnosis of cholelithiasis. Upper GI endoscopy for diagnosis of peptic ulcer disease.
Doctor, what about the treatment?
Treatment depends on the underlying cause. If patient is in shock, resuscitation with intravenous fluids and monitoring of vital signs.
Doctor, what about treatment of acute cholecystitis?
Conservative treatment. Nothing per mouth. Nasogastric suction. Intravenous fluids. Analgesics, tramadol hydrochloride or pentazocine. Broad-spectrum antibiotics. Second generation or third generation cephalosporin with metronidazole administered parenterally. Monitoring of the patient, pulse, temperature, blood pressure. Respiration, fluid intake. Output, symptomatic improvement and improvement of abdominal findings. Depending upon response to conservative treatment, further treatment is planned. If patient responds well, discontinue nasogastric suction and intravenous fluids followed by fat-free diet and cholecystectomy after 6 to 8 weeks. Interval cholecystectomy. Early cholecystectomy. Assess fitness for anesthesia and same hospital admission and do cholecystectomy operation 2 to 3 days after the acute episode has subsided. Urgent exploratory laparotomy is indicated when there is doubt in diagnosis. If patient does not respond well within 48 hours, indicated by persistent pain and vomiting, persistent tachycardia, fever, increasing tenderness and appearance of rebound tenderness. Cholecystectomy may be done provided the surgeon is experienced, as the operation is very difficult. The gallbladder wall is friable, edematous, and there are lots of adhesions. If anatomy is obscured and gallbladder wall is friable and patient's general condition is not good, simple cholecystostomy is to be done followed by cholecystectomy after 6 to 8 weeks.
Doctor, what about the treatment of acute pancreatitis?
Conservative treatment. Nothing by mouth. Nasogastric suction. Intravenous fluid. Prophylactic antibiotics. Analgesics. Surgical treatment is indicated for complications such as phlegm, pancreatic necrosis or pancreatic abscess or pseudocyst.
Doctor, What about the treatment of peptic ulcer disease?
Conservative treatment. Bland diet. Anti-secretory drugs, H blockers. Ranitidine or famotidine. Proton pump inhibitors. Omeprazole or pantoprazole or zomeprazole. Sucralfate. Provides a protective covering over the ulcer and hastens healing. If H. pylori is demonstrated. Anti-H. pylori treatment. Surgical treatment if failure of intensive medical treatment. Intractable symptom. Development of complications. Perforated peptic ulcer. Resuscitation of shock with intravenous fluid. Correction of fluid and electrolyte imbalance. Broad-spectrum antibiotics. Nasogastric suction. Emergency laparoscopic repair or exploratory laparotomy. Closure of peptic perforation and peritoneal toileting.
Thanks, doctor.
Thanks for you and for your subscribers.
Thanks for watching. Hope to see you again in next videos. Do not forget to like and share our videos and subscribe to our YouTube channel No1doctor and share our videos with your friends on social media. With my best wishes.